Good evening and welcome to Doctors on Call. I'm Dr. Ray Christensen, a faculty member with the Department of Family Medicine and Biobehavioral Health at the University of Minnesota Medical School, Duluth campus. And I'm also a family medicine doc at Gateway Family Health Clinic in Moose Lake. I'm your host for our program tonight on neurologic problems, headaches, strokes, MS, Parkinson's, and possibly some head trauma and other things that we may throw in. The success of this program is very dependent on you, the viewer. So please call in your questions and send them in to our email address at ask@pbsnorth.org. Our panelists this evening include Dr. Ken Ripp, a family physician with the Community Memorial Hospital Rader Family Clinic in Cloquet, Dr. Paul Sanford, an internal medicine specialist with Aspirus St. Luke's, and Dr. Vikram Jahad, an interventional neurologist with Essentia Health. Our medical students answering the phones are Nicole Fall from Pine Island, Minnesota, Tommy Martin from Tacoma, Washington, and Wyatt Windhurst from Alexandria, Minnesota. And now on to tonight's program. Gentlemen, thank you for joining me tonight. There's a lot of things that we can talk about. I think first it'd be nice just to have you talk a little bit about your practice and what you do. Ken, do you want to lead off?
I'm just a small town family doc. I've been there for 30 years now, and just mostly clinic-based, still get in the hospital, some, not as much as I used to, but so a little bit of ER, a little bit of hospital, just taking care of patients in the hospital, so.
Paul?
Yeah, I'm an internal medicine doc. I don't do hospital anymore, but all in the office, just thinking about things.
And Dr. Vic?
Hi, my name is Dr. Vic, and I'm one of the stroke and interventional neurologists at Essentia. So essentially what we do is deal with problems of the blood vessels of the head and the neck and the spine exclusively, like strokes and people having aneurysms and bleeds in the brain, those kind of things. And I've been calling Minnesota my home for the past 15 years and Duluth for almost like 8-9 years now, and I've been loving it.
Good. I think a good place to start probably is on stroke. There's been a lot of changes since I left emergency room and that part of practice over the last few years, and we've gotten to more stroke centers and so on. Ken, what do we mean when we say stroke? What's that all about?
The stroke is, there's two types of stroke. The majority of them are a blocked blood vessel going to the brain. So there's a part of the brain that's not getting enough oxygen and nutrition, and so that part of the brain can die unless we intervene. And then there's a type of a stroke where a blood vessel breaks open. That can be even more catastrophic because the blood can just accumulate in the brain, and blood in the brain is very irritating. So,
Paul, anything to add to that?
Oh, I mean, those are the main types of stroke. If you take away oxygen and glucose, the brain is not happy.
Well, it's one of the things that I think is interesting. I am old, and it used to be we started looking at heart hospitals, and then as I came to the university, we started looking for stroke hospitals, and I really wondered how that was going to work out. And Dr. Vic, there's really been a lot of changes with stroke and a lot of things that you can do. So if someone has right now, if we have somebody with an acute heart, pretty much it's get them in, do the intervention, and we don't treat heart attacks anymore. It's gone away. How does this work with stroke, and what are we looking for time-wise and so on?
So essentially it runs along the same lines, like time is brain, because with every passing minute you're losing brain cells. So every minute the part of a brain doesn't get oxygen, you're losing close to 2 million brain cells, and which are never going to grow back. So that's a pretty devastating outcome when you keep on adding the time that the brain is deprived of oxygen and glucose. So it behooves us to get the patient in a timely manner, first to the nearest center where they can get the clot busting medication. And from there on, they have to get to a center where if the blood vessel is blocked, occluded, then a neurointerventionalist can go in using a catheter and retrieve that clot and open up that blood vessel to restore the blood flow to that part of the brain and restore the oxygen, restore the glucose, all the nutrients that are needed to keep the brain viable.
And I know it works. It's great. I've seen a few patients. Paul, what do you look for? My real question for you that I didn't get it verbalized was, how do you know when someone's having a stroke?
Well, when people lose their symmetry is one thing. All of a sudden, my left arm, I can't move it. Or half the face is down, or you're losing vision in one eye. Any type of alteration in normal function, you gotta hunt right then for stroke.
And the idea is move fast.
Quicker the better.
Time is
Time is
brain's-
brain, and in fact, there is one easy mnemonic to remember for patients, also families and anybody in the community. It's called be fast. So wherein B stands for balance. If you are losing balance, like as if like you're tipsy but without having had any alcohol. E is for eyes. So if you're losing vision or loss of vision on one side. F is for face, so facial droop, as you said. A is arm and leg, so weakness, heaviness on one side of the body. S is for slurred speech. So if you have any of these symptoms, then T is for time. Call 911 or go to the nearest ER.
How does this work? You work for Essentia. We're dealing with Northwest Wisconsin, Northeast Minnesota, big areas. How is that working out with travel time? And it's really tough. Somebody's coming in from the Northwest angle or wherever.
Yeah, and actually we deal with this day in and day out. It's a huge geographical catchment area that we have to deal with, right up to the upper peninsula of Michigan at times, when in patients the transfer time itself might take some couple of hours or more. So, and in inclement weather that we can have in Northland. So it's very important for good recognition of those stroke symptoms, getting them to the ER in a timely manner, airlifting them and bringing them here. So that's very, very important.
The one other thing before we leave stroke, I think we've covered it pretty well. We were talking a little bit earlier about head trauma, and how does your interventional skills, how does that work with head trauma? So a subdural, epidural, or whatever.
Yeah, no, that's a very interesting point, because nowadays new research keeps on coming in. It's a very rapidly evolving field, and as we know, in Northland we have a huge density of octogenarians, nonagenarians, and even centenarians, like older patient population. And trauma is unfortunately one of the things that older patient population we have to deal with, and patients have to deal with, and they can have bleeding inside the brain. It's a unique kind of a bleed wherein the bleeding is not within the substance of the brain itself. It is called subdural hematoma because it is within around the dural layer, so it's between the skull and the brain substance. And over time, the blood can keep on accumulating, and it can present in a very insidious manner, very progressively, slowly. So what we can offer to supplement surgery is put in again a catheter-based approach, wherein we put in the catheter through the groin, go all the way up to the neck, and then trace the blood vessels that go along the outside, called the middle meningeal artery, and they go along the scalp, and then they dip into these membranes. And the idea is we can put in some particles or something to block off these small branches. And blocking off the blood at the source itself helps to prevent reaccumulation of the blood, and that way it can prevent the recurrence of subdural hematomas. And that allows older patient population to make a pretty good recovery and still maintain their independence as long as they can. And that's the goal behind this.
Very good. Thank you so much. It's a lot of information. Ken?
Yes.
We're getting some questions on multiple sclerosis, so I'm going to switch gears
All right.
just a little bit. Can you help us out with what multiple sclerosis is?
So multiple sclerosis is a condition, and there's several different types and how it progresses, but you have in the brain, there's parts of the brain that starts to lose the coating, and then you have these glial cells that start to grow, and you can get some little, almost like scar formations in the brain. And it tends to present, it can be tricky to diagnose early because the symptoms can be very subtle, a little loss of coordination, a little maybe one day they're not able to use their hands so well and then they're better. And these are young people often. And so unless you catch it at the time and examine at the time, you might not find symptoms. So it is a sort of a search, and sometimes it takes us a few visits to say, wait, this is what happens. And a lot of times they can have an episode, and then it can be weeks, months, years, or only have one episode in their life. And so it can be hard. If you have MS, it can progress. It can be a steady progression. Some people just have one event, or some people just have an event every so often, and then some people have an event and they lose a little bit of function with each event.
Paul, is there any way to treat that? And one of the questions that comes up, and Dr. Vick may want to jump in on this later, also, they're talking about stem cell transplant therapy versus current MS therapy. I don't know about stem cell, and as far as current MS therapy, mine has basically always been physical therapy, good care, and I don't know really any medicines for it.
There are a lot of medicines now for
Yeah,
MS.
there are, and varying amounts of improvement that might be affected, but there's nothing that's going to cure it, unfortunately.
The hope is slow progression and keep function, and some of the newer medicines can be dramatic, but stem cell, that's going to be at a research facility. You know, that's more of a clinical trial stuff. No one is doing that routinely.
I agree, and there might be some anecdotal reports that people might have some improvements, but again, unless there is a good clinical trial that shows efficacy of stem cells, it would not be mainstream treatment. But I should say that MS field has really, by leaps and bounds, there are newer drugs coming out every couple of years that have shown a lot of promise.
Mm-hmm.
Yeah, and with good improvements and good ability of patients to maintain their independence over a long period of time.
Paul, what are some of the initial symptoms for MS?
Well, a little bit of spasticity, weakness that will, suddenly become worse, double vision, trouble when you're swallowing where things might go down the wrong hatch or come out your nose. A whole spectrum of different symptoms. So if you're trying to eat a cheeseburger, it becomes more difficult.
Just keep going with that, Ken. Is there anything diagnostic? I think it really comes down to history.
So what will happen is a patient will present with the neurologic symptoms that's acute and diagnosable, meaning, oh man, your arm is spastic or weak, and that's not right. And that will lead to usually an MRI is the best test to look in the brain and sometimes the spine looking for any plaques. And so a lot of times we'll have suspicion and we look. And we're hoping not to find anything because it is not a great diagnosis. Hopefully it was just a little nerve irritation goes away, but that's how we usually do. So it's MRI. Sometimes people will do a needle into the spine, take out fluid, and they can make a diagnosis that way too.
Person calls in from Brimson with a recent sensation in the left shoulder, like bugs crawling. Is that neurological? Should that person see a doc? Paul, I'm throwing this one your way.
Yeah, well, if you don't look at it and see bugs crawling, then you have to think about something irritating one of the cervical nerves from the neck. But you really have to examine the patient, check strength, check reflexes. But until it's proven otherwise, it's probably bugs.
Or shingles.
Oh, yeah, shingles, that's right.
Vic, this might be more your direction. Severe cervical degeneration with spinal stenosis, pinched nerves in the cervical spine causing severe headaches. What can this person do? NSAIDs don't work. Heating and stretching help.
So that's a very good question because this is a very commonly seen ailment. As people age, they are going to have some arthritic changes, so there is going to be arthritis. And then the spaces between the vertebral columns, they are going to decrease. So naturally, the nerves that are exiting out at the neck, they are going to get pinched and going to cause neck pain. And sometimes this neck pain can be radiating towards the head, and then you can have headaches from that. We actually can call them cervicogenic headaches, like headaches that are actually originating from the neck. So of course, these can have several issues. In addition to headaches, if the nerves are getting pinched too much and they're going towards, they're supplying the strength in the arm, then you're actually going to start feeling weakness in the arm or sensory problems in the arm. So it has to be like a graduated approach because it depends on how bad or how severe the narrowing or the stenosis is. So the best way would be to treat it medically first and physical therapy, allowing the spaces to open up. So just gentle exercises, those kind of things. If that doesn't help, then the next step would be to get some injections like some cortisone shots to decrease the inflammation. And if that doesn't help, then obviously the primary care provider or the interventional pain provider, they are going to refer to the neurosurgeon to see if the patient would qualify for surgery to open up the spaces and allow the nerves to breathe a bit more. And possibly if it's even causing problems with the spinal cord itself, then obviously the patient is going to need surgery sooner than later.
Paul, migraine headaches.
Yeah.
Give us a little brief primer on that.
Well, when you have
Primer, I guess, is a better word.
Primer, yeah. When people get a one-sided, profound headache, sometimes preceded by lights, flashiness, associated with nausea, vomiting, it means that the vessel, and actually two types, one where the vessel is dilating too much and the other one where it's crunching down too much. And if you have, there are different ways of treating it, but if you use a triptan type medicine in one with, narrowing, it can make a complete stroke. So they can be very, very serious, and you have to have somebody who knows what they're doing, find out what type of migraine and how to prevent it. And lots of good prophylactic meds for preventing migraines.
Ken, is the muscle contraction headache, we've heard a little bit about that before. Are they all related? If years past, we used to consider it kind of a continuum.
Well, so there's the classic migraine headache where you get unilateral pounding headache associated with other neurologic symptoms, the nausea, some vision changes. And then a tension headache is more of a band-like pressure headache, and usually people get that with stress and they rub their head. And that's it's on a spectrum. Some say it's part of migraine, some say it's not. It's not like there's not a blood test you can do to tell the difference. The treatment's a little bit different. So the migraines, there's some specific migraine-specific treatment. The tension headaches, sometimes the migraine medicines don't necessarily help that, but they do, Tylenol, ibuprofen, the over-the-counter stuff really can help that. And then it becomes a lifestyle thing. Make sure you're eating well, hydrated, exercising, getting your rest, not too many cheeseburgers. So, so lifestyle for tension type headaches can be really helpful.
Little switch in discussion. There's a question here about myasthenia gravis.
Oh, boy.
Yeah.
Is this a progressive terminal disease, or are there treatment options?
Boy.
This question comes from Cloquet, Dr. Rip.
I know.
Yes, oh boy.
I will put in 1 week. I diagnosed 2 cases in 1 week.
Oh, it's spooky where the acetylcholinesterase binding, proteins the nerves don't communicate with each other, and some medicines like pyridostigmine, can help slow the progression. But as far as I know, there's no way to stop it.
We're going to move on now to Parkinson's. It's been kind of sitting on my list a little bit.
Oh, boy.
This person had a recent diagnosis of Parkinson's in the family. Any advice for family members? So I'll look to you guys for this a little bit regarding supporting this individual and recommendations for medications. And Vic, you can jump in too.
So as far as if you do have a family member who is a close relative, that does increase your risk. So there's no way to prevent you from getting that other than taking care of yourself, avoiding head trauma. That's Parkinsonism, which is different than Parkinson's disease. Once you have the disease, it really depends upon onset and symptomatology. Some people's symptoms are more rigidity, they have a hard time getting going, and some people are bothered more by the tremor. So based upon the age and the symptoms, we sort of direct our therapy to treat those symptoms. And the hope is to control it well enough. If you have severe Parkinson's and it's disabling and the medicines aren't working, then there are, interventions such as going into the brain and putting a stimulator in, which is not something we do in the office.
No.
Speak for yourself. Yeah.
The key with Parkinson's would be to make sure that you work with a neurologist who specializes in that, like a movement disorder specialist, because there are lots of treatment available and they have to be provided at the right time. So you do not want to delay for example, somebody who could be a candidate for deep brain stimulation and DBS, those kind of treatments, because if you wait too long, then by the time it might be too late if the dopamine receptors, everything is already depleted.
Yep.
So, and again, working with a good movement disorder neurologist would be helpful, because sometimes you have to titrate these medications in a manner that they are very helpful in allowing the patient's rigidity to be overcome and allowing them movement and ability to move around, but at the same time not having to deal a whole lot with the side effects of the medications also, because some of these medications, as we get older, they will have quite a bit of side effects, and then it almost becomes like a juggling act wherein you have to manage the medications and also the side effects, and what is the worst.
Right.
Yeah.
Can neuroleptics cause this kind of problem too?
They can, certain medications can give you a Parkinson's appearance, but is not the disease. And so they can, and so that's one of the things where we have to sort out, okay, when you see a patient with a tremor, if they're coming in with a tremor, okay, is that just a familial tremor? Is that a Parkinson's tremor? Is this a side effect from a medication? Which it certainly can be. So we have to sort it out. So the first thing, you know, I'm sure Paul does the same. Any patient comes in with a symptom, we look at their medications, we look at, you know, to see if there's a side effect, which can happen.
Yep.
We talked about dementia earlier. Does dementia travel with Parkinson's disease?
Well, you can often find dementia in people with advancing Parkinson's disease, but not necessarily. I don't think it's a continuous process, but the Parkinsonism has so many different areas that it affects, and one of the biggest ones that I see is people will lose their autonomic or involuntary central nervous system control of things like mobility of the intestines, maintenance of blood pressure when you go from standing up to lying down. The biggest thing I worry about is a fall and a broken hip.
Yeah, there is one particular subset called the Lewy body disease,
Yeah.
where Lewy body
Oh,
dementia,
behavioral.
wherein you can have some Parkinsonian features, you have dementia, you can have like hallucinations and aggressive behavior, and that can be very challenging to manage also, because it depends what the patients are presenting more with, like is it dementia or Parkinsonian features. So again, needs a good incisive history taking and examining the patient and hitting the right diagnosis.
Probably for you, Vic, elderly patient hydrocephalus treatment.
So hydrocephalus, I would say, and I always like to say, it's a diagnosis of exclusion. You have to make sure that you have excluded all other possibilities for the problems that are being attributed to hydrocephalus before committing them to a treatment wherein you have to put in a drain to take the excess fluid out directly into the peritoneum, like the abdominal cavity. So hydrocephalus is just accumulation of more and more fluid inside the fluid-filled spaces in the brain, and that's why these patients may have some problems with lack of cognitive decline. They are not able to ambulate well. So to help these patients out, a neurosurgeon can go in and put in a drain directly from these fluid-filled spaces and track it down into the abdominal cavity.
Effective treatment for essential tremor. What is it?
Oh, there's not a
Yeah,
beta
fight this one out,
blockers,
you
beta
guys.
blockers, and primidone.
Chairs, yes.
Yeah. Alcohol, yeah. Narcotics, yeah. So yeah, a little bit of beta blockers, which is a blood pressure medicine, can work. Primidone can work. We sort of, you know, sometimes you get lucky and it helps a little bit. I did have one person respond this week.
You did?
Yes.
Oh my gosh.
You know, and so that, you know, so sometimes and then it is a tough one. That is just a tough one.
That is. There's no simple cure.
No.
Other tremors that we should worry about? Parkinson's doesn't necessarily, it's a different tremor. You know, it's
Yeah,
Classic.
the pill rolling.
Classic pill rolling, yes.
as we kind of come to the end, we're coming into the spring season. You guys are both taking care of people out in the country. Lyme disease is coming up at this time of the year, and we're going to have a program at the med school, Dr. Ben Clark, and we're going to just showcase this real quick. Lyme disease can cause neurologic disease also. Vic, you may have something to say about that. But I just encourage people that they are welcome to come to this program. It's free. There's parking in the Gold Lot, and I can't remember what day it's in March. Any thoughts on Lyme?
I mean, we live in endemic Lyme country, so actually we do tend to order Lymes on anybody who comes in with very vague symptoms, because we always feel that Lyme should be checked, because Lyme's disease is one of those diseases that can mimic a stroke. It can mimic several other pathologies also. So early treatment, I mean early identification and treatment, and Lyme's can be, like you can cure like Lyme's, and so that should not be a problem, like once you capture and know.
deep brain providers, deep brain stimulation. Are there providers in Duluth that handle this problem? You got about 30 seconds.
I think, to the best of my knowledge, most of the patients, they tend to go to the cities. Yes. Yeah, or Mayo. Yeah. But
wanna
once the deep brain stimulator is put in, then a neurologist who specializes in movement disorders, or they have good experience, they can do the programming too. So the patients don't have to keep on going to the cities all the time.
Very good. Thank you, guys. This has been a great discussion. I want to thank our panelists, Dr. Ken Ripp, Dr. Paul Sanford, and Dr. Vikram Jadhav, our medical student volunteers, again, Nicole Fall, Tommy Martin, and Wyatt Windhorst. Please join Mary Morehouse next week for our last program of the season on the DSM-5. Thank you for watching. Have a great night.